It's 4 p.m. East African time. And so we'll go ahead and start. Hello, everyone. Welcome to this special COVID-19 Echo Session number 33. I'm glad to be your host. My co-host today will also be Mr. Silva Mashate, a program manager at ASLM, and he'll get an opportunity to introduce himself shortly. ASLM and partners have created a series of webinars and echo sessions to address the COVID-19 pandemic. At the beginning of the year, we have seen a rise of infections and also emergence of new variants. Countries have been scaling up testing for COVID-19 by scaling up antigen rapid tests. And recently, to support member countries, the Africa CDC has developed guidelines to support member countries to look at strategies and also algorithms of addressing the spread of COVID-19. So this session will focus on that, and we have 3 speakers. And now I invite my colleague, Mr. Silva Mashate, to introduce himself and also to introduce the speakers. As usual, if you have any questions, please put them on the chat box. And after the presentations, we'll have an interactive question and answer session. Thank you. Welcome, Silva.
Thank you, Collins, for the humble introduction. Hi, everyone. Good morning, good afternoon, and good evening, depending on where you are. Happy New Year and welcome to our special session of COVID-19. This is special session number 33, focusing on testing strategy for COVID-19 antigen rapid diagnostic tests. The start of 2020 has been a year that has started with challenges. We are seeing rapid rise in the spread of the virus. We have the new virus variants. And to urgently address this, many countries are now deploying rapid diagnostic tests. And in this effort, the Africa CDC has recently released the guidelines to expand the use of COVID-19 rapid diagnostic tests. The main focus and the aim of these guidelines is to support and facilitate member states with the recommendations on how to roll out these approaches. The guidelines are actually much needed at this point. And in this session, we are going to unpack and discuss the algorithms in the context of the testing in the different areas and address questions around this. Like Collins has introduced me, my name is Mashate Silva. I work for ASLM. I'm the program manager for the CHI United SARS Response project. We appreciate the support from United that has funded this project, and we thank the partners that we are working with, CHI and all the other partners. And in this meeting, like Collins has discussed, we have the ground rules where we request all the attendees to mute their microphones. We invite you to utilize the chat box to ask your questions and have any clarifications addressed. And ladies and gentlemen, to discuss this important topic, we have Mr. Nqobile Ndlovu, Chief Executive Officer of the African Society for Laboratory Medicine. And then after him, we shall have a presentation from Dr. Yenew Kebede. Dr. Yenew Kebede has a high profile. He's the head laboratory systems and networks at Africa CDC. And there we also have the next presentation will come from Dr. Moyo Sikhulile. Dr. Moyo Sikhulile is the Deputy Laboratory Director of Botswana-Harvard Partnership. He's a medical virologist and works at the Botswana-Harvard Institute, Harvard 8 Institute, and he has lots of experience in this area. He's a member of the Botswana Presidential Task Team, and is a researcher and a mentor of so many experiences and publications. So ladies and gentlemen, at this point, allow me welcome Mr. Nqobile Ndlovu to make his presentation, and thereafter we shall welcome Dr. Yenew and then Dr. Sikhulile. Nqobile Ndlovu, CEO ASLM, you are welcome to make your remarks. Thank you.
Thank you so much, Silva. Thank you so much, Collins, for the introduction. So please allow me to share my screen right now.
Mr. Ndlovu, you are a co-host, so you can share.
Can you see my screen?
Yes, we can.
Okay, so thank you so much. Let me start by welcoming everyone and Happy New Year to you all. Thank you so much for joining us in this very important webinar as we start 2021 with its challenges. I would like to appreciate the Africa CDC even for launching this very important guidance document that we are going to be discussing today. This is a document that was launched in December last year, December 16th, 2020, in a bid to really address some of the testing challenges that most of the member countries have been facing. I would like to also acknowledge some of the partners that were heavily involved in putting together this important guidance document. I would like to acknowledge the Clinton Health Access Initiative team. I also want to acknowledge even FIND, even for their contribution, and also ASLM also for bringing a team together to make sure that we have a guidance, especially for the African region, given the many challenges that we are having in terms of the COVID and also in terms of trying to address the testing gap. So our webinar today largely is going to be focusing on this interim guidance document that I've put up on my screen, the interim guidance document on the use of rapid antigen tests for COVID-19 response. I decided to talk about the rapid antigen testing, what's its relevance and importance in our time right now as a continent, and how it can play its role as a way of complementing and as an alternative even to some of the molecular tests that we have. This map, most of you might be very familiar with this. This is a report from Africa CDC, and it shows some of the statistics in terms of new cases. And this report was accessed on the 19th of January 2021. And as you can see for yourself that we are getting to another wave across the continent, which is not a good sign. And as a continent, we need to do more, especially in terms of testing. When we test, we identify the cases, then we isolate these cases so that we can begin to reduce the impact of this COVID-19. So we are also facing a very difficult time as a continent. I also want to superimpose also the diagnostic journey also that we have been experiencing during this outbreak. As you already know, during the early months of this outbreak, this was mainly done by Senegal, and it started with Senegal and South Africa, where they started doing the manual PCR testing. And of course, Africa CDC quickly stepped in to provide the training that began to be rolled out in a number of countries. But this is where we started in terms of the journey of the diagnostics here in the continent. And of course, a lot of discussions then picked up around the use of automated platforms, the discussions around multiplexing, the discussions around integrated approach to testing as COVID was becoming a threat to the continent, and also trying to utilize the resources that we have as a continent. And we also witnessed even the introduction of the antibody testing also as one of the tools that we can also be using to try and understand this epidemic, and also begin to put into place some of the strategies to curb and to control it. And recently, towards last year, we began to see the introduction of antigen testing, COVID rapid antigen testing, which we are going to be focusing on today. I've decided to just reflect this journey so that as a continent, we begin to realize some of the tools that we have at our disposal. And not only that, but we begin to think deeply, how do we harness this? How do we make the most? I know sometimes the tendency is to wait for the new technology to be developed, and we hope that this new technology is going to address our testing needs. But sometimes we forget that some of these tools are already with us. We need to plan together. We need to discuss these tools together, and they might not be perfect tools that we have, but this is what we have, and we are faced with a situation like a war, and we need to bring everything that we have. So today, as we are looking at the antigen testing, I want us to really refocus ourselves and begin to ask ourselves the question, what is the maximum benefit that we can get from the availability of these antigen testing? Because as you can agree with me, these figures most likely are an underestimate in terms of the cases. There is either under-reporting, there is either under-testing in many countries, and we have an opportunity today that we can begin to utilize these antigen tests to really decentralize, really to cover the gap, really to increase our testing capacity as a continent. Just to reflect back on a few things, we all agree that diagnostic testing for SARS-CoV-2 is vital for the control and the suppression of the COVID-19 pandemic in Africa. And we need to test all the individuals with the symptoms that are consistent with COVID-19 as quick as possible. That is very important. We don't have much time for us to respond. So as much as we can, we need to test these people, isolate them as quick as possible. And this is heavily dependent on the ease and timely access to this testing. We are faced with a major issue which we have observed across many countries, which is the issue of the diagnosis gap between the PCR testing capacity in laboratories and the number of suspected cases to be tested. So this gap still exists, and in many places it's still growing. The gap between between the capacity we have and the number of suspected cases that needs to be tested. And another challenge that we are facing also is the access to this molecular test and the timely provision of these results so that they are clinically relevant. So the turnaround time also becomes a challenge in addition to the access of this molecular test. So we are happy that we have this added tool that we can utilize as a continent, the COVID-19 rapid antigen test that are easy to use and are complementing and also an alternative even to the molecular test, and can be done within the 15 to 30 minutes and can be used at the point of care. I wanted to show this slide just to reflect on the benefits that we need to begin to consider as far as COVID-19 rapid antigen test in terms of number one, availability. We know that the PCR test, they have a limited supply of automated PCR tests available across the continent. But when we look at the antigen tests, these are available in large quantities, very sufficient even to fulfill the entire testing demand. So, and the impact that we see is that it increases the supply in the market to meet the demand for resource limited countries for our COVID-19 diagnostic test need in our African continent. If we look at the issues around cost, we're looking at PCR cost roughly $10 to $20. I think this is very conservative. I've heard figures of around $60, $80 in some countries. So it kind of really strains the limited resources that we already have. But when we look at the antigen test, these are going less than $5, almost 3 to 4 times cheaper than the PCR test. And it allows, in terms of impact, it will allow the countries to purchase more tests with the limited funding available, leading to increased access to testing. In terms of coverage, typically The PCR tests, these are centralized, they are in centralized laboratories, and they do not have the reach, especially outside the urban areas. But when we are looking at antigen testing as point of care, these are flexible. They can be easily decentralized to all settings. And the impact that will be realized with this antigen testing is that it will support decentralization of testing to lower health facilities and even to remote regions, enabling increased testing coverage. And lastly, the issues around turnaround time become very important because we need to act upon this result as fast as we can if we are to really slow this pandemic. On average, if we are looking at PCR tests, these have been varying from 2 to 5 days, but with an antigen test, we are looking at between 15 to 30 minutes. And the impact is that there will be, it will enable immediate decisions to be made that will support patient care, contact tracing, isolation, and treatment. So this is very important for us as a continent, especially realizing that we're still having a very huge testing gap for us to understand the COVID pandemic in our continent, and also even begin to mount the right response to it. Now, for us to realize the impact of COVID-19 rapid antigen test, we also need to build some very important support systems to this. Number one, I'm so happy to also announce that the Africa CDC, through the PAC initiative, has launched a comprehensive training and supervision program. So we need that so that we ensure quality of results. And also the issue of engagement in quality assurance activities. There's a guidance again that has been launched by the PAC initiative partners there. And also in the process, we are not dismissing the PCR role. It is very important. So countries and as a continent, we need to establish a clear role for both COVID antigen testing and also the PCR within the new testing strategies. Now, one of the most important issues that we also need to think about and continue to work on is, as we decentralize testing, the issue of capturing and integrating testing data will be very important. We need also to access, we need also to make visible some of the testing that will be happening using COVID-19 antigen rapid test. And lastly, we are all learning. There's always new information around COVID, and there's a lot that is still unknown. So even as this guidance document was recently launched, there will be continuous learning from what is happening within the countries, what is happening even within the continent and even globally, so that this guidance document also and all the testing strategies that are going to be discussed today will also be updated and be relevant to the pandemic that we are facing. So just to summarize some of the important issues is that antigen testing will be very important when it comes to reducing the testing cost, the issue of resources, and could even double the testing program within the current existing budgets. It's something that we need to also take into account. And also antigen-based screening programs would allow for greater movement of goods and people by identifying the infectious and symptomatic cases. And lastly, we are now talking about vaccination, but for us as a continent, achieving true herd immunity with vaccinations may take more than 2 years. And thus, diagnostics and particular antigen testing will be needed for managing the epidemic in the meantime. So as we continue our discussion today, we are going to be focusing on the interim guidance and also looking at the use case scenarios and also the associated testing algorithms. So thank you so much, and over to you, Silva.
Thank you, Ndlovu, for this opening presentation. And we realize that the CEO has highlighted issues regarding the antigen Rdts for COVID-19. We've talked about the need in terms of gaps between the capacity and the need that we need for our people to have the services, issues of access, issues of turnaround time, availability of the resources. And he went ahead to summarize the issues to do with, if we are to achieve what we need supportive systems, issues, how do we manage data? Thank you so much, Ndlovu. And at this time, I would like now to welcome Dr. Yenew. Dr. Yenew to give us some updates on the perspective from Africa CDC regarding the expansion of the SARS-CoV-2 rapid diagnostic testing. Welcome, Dr. Yenew.
Thank you, Silver. Thank you, ASLM team. Thank you, participants, for joining. Allow me to share my screen. Can you see my screen?
Yes, we can. Yes, we can. Thank you.
Okay, thank you. So, Ndlovu has really, presented a very good summary. What I would like to do is to really, to discuss the expansion of SARS-CoV-2 testing, especially, the role of antigen testing, by indicating where we are in terms of testing across the continent and what are the challenges and so on. I would like to start with what in the last minute Ndlovu said. The continent is now struggling with access to vaccine, and logistics associated to vaccination of large population will be a very big challenge in Africa. We have some commitments from the global community to allocate some amount of dose for the African continent, but I think that still is not enough. And then the effect of the new SARS-CoV-2 variant on vaccine effectiveness is not known. So there will be there is going to be a study. It's our hopes that the new SARS-CoV-2 variant, even if it has an impact on monoclonal antibodies, most likely the vaccine effectiveness will be okay, but it's not really known. So there are some groups that I know that are doing the study. Hopefully we will hear from that group really what the new variant is bringing on the efficacy of the vaccine. So I agree with Ndlovu that vaccine coverage to achieve herd immunity and then subsequently to have an impact on incidence of COVID-19 may take as long as 3 years in the African context. If we see measles today, where vaccination has been there for a long time, so vaccination coverage in many countries is low, and that's why you see, measles epidemic here and there. So if we start with a vaccine, that also requires a booster dose, according to some of the requirements from the companies, then it will be really very difficult to really, put all of your strategies in one basket, just, focusing only on a vaccine. Therefore, it's important for the continent to continue expansion of testing, and also, to continue, implementing infection prevention and physical distancing measures. This is what Ndlovu also said, immediate identification and isolation of case tracing contacts, that should be the usual practice. And I would like to bring one important issue here. If contact tracing is not possible because of the large number of cases that we are looking today, so testing will help to empower individuals to protect the people around them. So even if there are no health professionals coming to individuals' homes to do contact tracing, so once people know that they are positive, they have access to testing, and then they take their own measures to protect others, protect families. So that is really a very important factor why we need to continue with the expansion of testing, even if the surveillance team, the emergency response team cannot do contact tracing for large number of contacts. So we still feel that widespread testing will be important to limit the impact of COVID-19 in Africa. So where are we in the continent today? As of today, total of 30.4 million tests have been conducted. The positivity rate is quite high, 11%. For the continent to have a hope in terms of controlling the pandemic, the positivity rate should go down to 5%. So we are still at 11%, and it varies from country to country. Some countries do have even as high as 30%. That is equivalent with 22,714 tests per million population, which means that 2.3% of the African population has been tested. But if we see, the adequacy of testing, based on, expert opinion, optimal testing is considered to be 10 to 30 tests per every case identified. But the continent sits at 9 tests per case, which is on the lower side, indicative of, inadequate testing in the continent. So if I can a little bit do, a breakdown for test per case ratio, as I said, the target is 10 to 30. So 20 countries have less than 10, which is, inadequate testing. Some 26 countries, they are doing between 10 to 30, and then some 9 countries do greater than 30. So doing greater than 30 is okay. You may say, it's not economical, but it's still fine because they are doing more. However, all those countries that are doing less testing, test per case ratio less than 10, they should step up to expand testing. And then the positivity rate, as I said, the target should be less than 5%. To really have, to minimize the impact of COVID-19 pandemic. However, more than 39, around 39 countries to have positivity rate greater than or equal to 5%, which means that many countries have a long way to go to expand COVID-19 testing to really, reduce the burden of the pandemic. So we were also tracking the weekly increase in testing number. So recently, there is a significant increase. Most likely is maybe partly because of the availability of reagents and then introduction of antigen testing. So the average increase of testing per week is more than 946,000. And as I said, this could be especially, the recent change that we are looking. Could be because of the introduction of antigen tests in some countries, and also, some countries have also started getting access to adequate PCR reagents and supplies. So this has been shown, Ndlovu has shown this. I just brought it to emphasize that we are really, on the rise of COVID-19 in the continent. The southern region is contributing most, followed by north, west, eastern, and then central. Especially in west, east, and central Africa, many countries are not doing adequate testing. So with an increase in testing number, the case number will change. That really is an important message from this graph. And as you know, the continent is going into a second wave, fueled by the introduction of new variants, especially in Southern Africa region. And some countries are also reporting the same variant, both the UK and the South African variant. So most likely it looks, it's highly transmissible. So the cases are expected to rise in the next couple of weeks. So what is the testing target? As I said, number of cases reported is around 3.3 million. We have also discussed that, the optimal testing should be for every case reported, countries should do 10 to 30 tests per case. which means that we should be between 33 million to 101 million. Our actual testing number is only 30.4 million, which means that we are on the lower side of the target. So that's why, you know, introduction of antigen testing could be a little bit of help, I will say, because it increases access, simplifies the ease of really, you know, the procedure for doing the testing. And some of the challenges are mentioned in Ndlovu's presentation. Many countries still depend on more centralized testing, PCR-based testing. These are low throughput testing sites. They still depend on, you know, manual RNA extraction technique, which is time consuming. Specimen transportation is a big challenge. Test kits and supply shortage still in some countries, especially, you know, some additional supplies in addition to PCR detection and extraction kits. So there are other supplies. Some countries have reported, you know, shortage in terms of skilled human resource. And we have also noticed some challenge in terms of equipment maintenance and calibration. So all this can be somehow elevated if we can also integrate antigen testing with PCR technology. So this has been discussed. Antigen tests, these are very rapid. They give you results within 50 to 30 minutes. They usually perform best at early stage of the infection. They are generally less sensitive to PCR testing. However, there are some modeling studies that were done, you know, which are comparing frequency and turnaround time to have a significant impact as compared to sensitivity of test. This is true, especially in the African continent, where most individuals have not been tested. So because of the nature of this pandemic, most people are asymptomatic, they are not getting tested, they continue, you know, transmitting the infection. So if we can introduce a test that may be, you know, relatively low sensitive, less sensitive, but we can do it frequently. We can test it today, tomorrow, after a week, and so on. And then we can give the results immediately, then that compensates the loss in sensitivity as compared to PCR testing. That's why we are really, you know, advocating the widespread utilization of antigen testing as a means to increase testing number in the continent. So the interim guidance is available, it's downloadable at the Africa CDC website. It's almost similar to WHO guidance. However, we have made slight modification to address Africa-specific needs. There are some few changes from the WHO recommendation. And then the group of you know, different partners came together and we produced a comprehensive training package which is available with at ASLM. We provide TOT training, which was attended by 14 or so countries. And now many countries have started rolling out of the training. So we expect, you know, more and more countries to really roll out this antigen testing. On the specifics of the guidance, in terms of testing algorithm and so on, there will be the next presentation. Thank you for the opportunity. We as Africa CDC are really grateful for all the support that we are getting. And we really, you know, depend on the hardworking people in different laboratories across Africa. So this is a time that we need to stick together, work as a team, and try to, you know, do everything possible to change the dynamics of this pandemic. Thank you. Over to you, Silver.
Thank you, Dr. Yenew, for the presentation. Dr. Yenew has highlighted a couple of things, including the pending challenge ahead of us regarding the how soon and when the vaccine will be available. And because we're estimating it to be more than maybe 2 years, we need to have testing available such that we have to expand the identification of the sick or infected persons. Dr. Yenew has further gone to tell us that the problem is big. We are so far having a positivity rate of about 11%, and yet we would wish it to be at least less than 5%. And yet the population which is tested so far is so low, only about 2.3%. So COVID antigen Rdt has come in at the time when it's most needed to increase this coverage of this service. Now, next to present to us is Dr. Sikhulile. Dr. Sikhulile, you are welcome to give us your presentation and look at the insights of the details regarding the algorithm and how to move about this. Thank you so much, Sikhulile. And we have about 20 minutes to the top of the hour, and then we shall have a session for a few questions. Thank you. Welcome, Sikhulile.
Thank you, Silva. I appreciate the opportunity to present this work, which has been a collection of so many people that I would acknowledge right away, with the leadership of Africa CDC, ASLM, FIND, and CHAI. We appreciate the number of external reviewers as well that helped to put this document together, and whose rationale well explained by both Ndlovu and Yenew in the previous two talks. So it is my honor and privilege on behalf of the team that put this document together to present to you the guidelines. The aim of the Africa CDC guidelines is to provide member states with recommendations on testing approaches and algorithms to help curb the growing spread of SARS-CoV-2. I think the rationale and the...
Excuse me, Sikhulile, have we moved the next slide? It seems like we are frozen on the first slide. Are you still on the first slide?
I'm okay. I'm about to move to the next slide.
All right,
okay.
Just wanted to confirm. Thank you. Go ahead.
Thank you. I was just highlighting the much needed guideline, as Ndlovu explained, that this is a tool, one of the tools that we have in terms of the response, that is needed to support our programs. So in this session, we will try and unpack how to use the guidelines in the context of testing in different settings to address some of the questions on how best to deploy the antigen test to more effectively control the epidemic, whose rationale in terms of the numbers, you have seen the numbers, you have seen the trends, you have seen the rationale in terms of cost effectiveness that they've been addressed. So let's dive into the guidelines and look at what we can glean from the guidelines that are out there. I will not repeat what has been said, but we can see that the Rdts are providing an additional advantage that we can now expand testing beyond the lab. As you see, we started with high complex testing in centralized labs, transporting samples, different regions, with the challenges of cold chain, the challenges of turnaround time. So Rdts are kind to position as a tool to complement in a testing strategy that can complement what the countries are doing. So there are two types of Rdts: the antigen test, just upfront so that everyone can be clear, and the antibody test. So the antigen test, which directly detect the viral antigens, and the antibody test, which detect one or more types of antibodies against the virus produced by the host immune system. So just so you see the difference. So the antigen tests are much closer to the PCR because they are targeting some aspects or some portions of the products of the virus itself, as compared to the antibody that is looking at host response markers. So the guidelines that you see are developed have been developed by with the leadership of Africa CDC and are similar to the guidelines and are trying to address more specific. I also want to highlight what Yenew provided is that in order to make sure that there's quality of work in expanding, training is available. Many countries have started rolling out. We'll learn more lessons as we go, but the training package, those who haven't tried, countries who haven't tried the training package, is a very good starting tool. It addresses many aspects of antigen testing. So this reference guidance only refers to the antigen Rdts. There are other guidelines, there are other recommendations that you can find online concerning antibody testing. So just to go back to just give a context, why do we need the guidelines? And they are helping to interpret the results in context. Yeah, I've also that although we don't have the perfect tools, if they are used well and with increased sampling and testing, they are actually, the modeling results are showing that you get high impact for epidemic control than waiting for a perfect test. So the antigen test identifies cases at high risk of transmission. So someone loosely called it, it's a test of infectiousness, just quote and unquote. So which is critical for stemming the spread of the epidemic. On the left, you can see this is viral load. So there's what we call a cycle threshold value. So this cycle threshold value is the number of that it takes for the virus to be detected. And you can see that if you compare the cycle threshold values and the normalized viral load, there is an inverse relationship. So the lower the CT values, the higher the viral load, and there is that relationship between the two. This is important in the context where we are going to apply the antigen test. So percentage of testing positive relative to CT values, you can see the percentage of samples that are testing positive in culture relative to CT values. And you can see that as you get to CT values of greater than 33, some publications 35, you begin to lose a culture positivity, meaning that most likely anything less than 33, some people say 35, you may be having a transmissible transmission risk. So now, in order to really understand why we say this antigen test identified cases at highest risk of transmission is to see this graph here that compares the PCR and the RDT. So this is a curve that shows with time from infection, the viral load rises up to a peak, goes down. You can see that early on, you see this is the threshold of PCR, and this is the threshold for the PCR, and you can see that it's lower than the threshold for the RDT. So this means that the RDT has a higher concordance in individuals with high viral load, and who are most likely to be the ones having transmission. So this becomes very, very, very useful, and this is what is being termed the infectious period. We need the algorithm so that we can take these items in context so that we can actually use. So antigen testing, therefore, is most sensitive when viral concentration is high. This is important, a point that you should take hold of as we move to other aspects of this presentation. So it means that we'll identify samples with high risk, or some would identify individuals with highest risk of transmission. So antigen sensitivity is lower concentration related with negative cultures with low risk of transmission. So it means that for lower viral load concentration, we must be able to interpret what a negative result means with Rdts. Okay, let's look at the guidelines. And so this is the guideline, Africa CDC guidance on antigen testing allows for their use in any setting, subject to conditions such as performance standards. So this is very important, is upfront in the guideline to say we are using these subjects to the following: the RDT performance characteristics as defined by WHO greater than 80% and sensitivity greater than 80% and specificity greater than 97% should be used, with a broader number of use cases and settings accessible for higher performing products. If you have higher performing products, even better. So the introduction of high specificity tests like greater than 99% is preferred in settings, in all settings, and in particularly in settings where you have low prevalence settings, to make sure that you can catch the truly classify individuals, especially who are negative. So the RDTs can be deployed in any settings as per these Africa CDC guidelines, though the use cases with greatest impact, epidemiological management goals should be prioritized. So there are cases with where there is greatest impact, where we identify especially individuals highest probability of transmitting the virus, where that should be really prioritized. The antigen test should be deployed as first-line test in contexts where nucleic acid test is not feasible. From the previous speakers, they talked about the challenges that we are having with increasing numbers. So lack of resources and turnaround time becomes challenging. Here are some considerations that are important, that are critical in the implementation of the RDTs. So high specificity, 99% and above setting, but may be of increased importance in settings where consequences of a false positive are impactful, either due to the need of epidemic management or economic consequences. Proper interpretation of antigen test results within these use cases is important for clinical management. So through the algorithms so that you understand what we mean by proper interpretation. If you read the guidelines, they expand more. So the accuracy of these results depends largely on the context within which these results are interpreted. This is very important, as you will see as we go into the different contexts, how these are applied. As you develop your in-country guidelines, you must make sure that you attend to the contexts that are important. Therefore, given setting, you should consider the tolerance and consequences of misdiagnosis, either false positive or false negative, which is critical. Now let's look at the testing strategy characterized by either exposure risk, whether it's known or not known. So in the testing strategy, there is this category, populations with known risk or exposure. So the testing scenario here is diagnosis in populations with known risk or suspected or confirmed outbreak. So there's been an exposure. So the scenarios that have been put together are confirmed suspected outbreaks where you have widespread community transmission, asymptomatic contacts of cases, frontline health workers, essential workers, and high-risk population, like in very crowded areas. So the location, as you can see, is classified here: health facilities, contact tracing response teams, closed or semi-closed settings. So these are the target populations that qualify under this testing strategy. So it's patients with severe presentation, You have symptomatic cases. As you can see, the risk of transmission is high. Contacts of confirmed cases, they might be symptomatic or asymptomatic. So as you will see, the next different strategy. So you have general population screening, and in the general population screening, you can see that we are looking at monitoring these incidents, the points of entry, educational institutions, workplaces, religious institutions. In this setting scenario here, we see that there are no suspected or confirmed outbreaks, and generally you may have a lower pre-test probability of being positive. Those are the locations of testing, and the testing population targets are travelers, teachers, students, administrative staff, factory workers, government employees, non-COVID patients, and other general population community testing and surveillance. So this is the strategy. So now let's dive in and open some critical aspect of the guideline that allows us to understand the interpretation of results. So we will start the first group, which we said is the populations with non-risk of exposure. And you can see this is the population that we are talking about: symptomatic cases, frontline healthcare workers, confirmed cases, or contacts of confirmed cases, or high-risk populations in confirmed outbreaks. In these populations, when you apply the antigen test, you get an antigen positive result. So positive results are more like positives. Can be interpreted as likely to be having SARS-CoV-2 infection.
Dr. Moyo, just a kind reminder, we have only about 7 minutes, just to update you on the time. Okay. Thank you.
That's good. That's good. If you have a negative test, implies that the infection is unlikely if there are no clinical signs. But if there are clinical signs and the test is negative, if you have high degree of suspicions and there are clinical signs, if the answer is no, you can manage as negative and wake up the cases with all other potential causes of illness. It may be something that you look at. And then you have a negative test, there is high degree of suspicion, either the symptomatic case. You can repeat the antigen test or preferably confirm with nucleic acid testing where possible, and you follow the management as possible. Okay. So special consideration is in that context. For close contacts, a negative result may not imply that there is no infection, as they can still be early pre-infectious stage. If you remember that graph that I showed you about the trajectory of infection, there is a small proportion that may be pre-infectious. So you must consider that as well. Thus, they should be considered with high degree of clinical suspicion and isolated accordingly if they are close contacts. For healthcare workers, regular screening is recommended where community spread is detected. Limited to no suspected cases, a positive result should be interpreted with caution due to the likelihood of positive results. So the recommendation is retest with antigen testing or preferable confirm with PCR. Now let's go to the general population screening, which is shown there. A negative result most likely is a true reflection of no COVID infection. So in this context, and further isolations may be required However, infection prevention measures should be followed as appropriate, looking at your guidelines of point of entry and your guidelines that you might have. So in all intents and purposes, in this category, negative is negative. A positive, on the other hand, it's an indication that you can isolate and manage as positive, and preferably confirm with RT-PCR where possible. As you can see here, the pretest probability of testing positive in this population is lower. So it's important that if possible, you need to confirm with PCR and manage accordingly. Other special considerations that are there in terms of two algorithms I've seen is routine screening in semi-closed settings, also making sure there's a monitoring of health indicators for decision-making to inform mitigation strategy. Member states should carefully choose appropriate tests depending on intended use. The tests have been assessed through a national emergency use authorization and or WHO emergency use listing, which is available online. Additional resources on appropriate quality assurance, which were mentioned in the previous presentation, are available through the Africa CDC web that I've listed there. Other considerations are data management, how to manage the data, reporting, those should be outlined, and continuous learning. And I welcome you to look at the ASLM training portal, where you can find more training that you can access and assessment that you can use. I'll spend little time on here, but here I was just trying to emphasize that with low prevalence, higher probability of false positive. However, at higher prevalence, there's also a probability of false negatives, depending on the performance of the kit. So this is important why we have those guidelines. And because I need us to have more time for discussion, I was expanding this in the next slide, but I think the summary for you is to understand that in a low prevalence setting, it's important that you understand that there's a likely false positive, hence the second guideline that we gave. But in a higher prevalence setting, there's a probability of false negatives, which is important to look at the first guideline that we gave. So this just emphasizes those, and I'll just pick a point there, like if the sensitivity is low, you have a false negative increase, then you have a potential for transmission, there's high impact. I'll conclude in the 2 minutes that are left, that we see that the antigen rapid tests are likely to have a very high impact in containing the spread. And this guidance will allow us to use in any setting, subject to conditions such as minimum standards. And also, as you implement these guidelines, allowing you to interpret results in context. This is also important, although vaccines are coming on, achieving herd immunity with vaccination may take up to more than 2 years. So that's the emphasis on diagnosis, particularly expanding antigen testing, helping contact tracing, making sure that we detect positives early, especially the positives that have high viremia, so that we can close in the epidemic. Training and quality assurance are critical. It's important as member states to plan the rollout, to plan the training, how you manage the data, how we'll make sure that all these plans together. And with that, I would like to acknowledge organizations and individuals that have contributed to the development of this interim guidance document that are listed there: African Society for Laboratory Medicine, Clinton Health Access, Foundation for Innovative New Diagnostic Find, and Africa CDC. And we have received a lot of external review and contribution to validate these documents. Thank you. Back to the chair.
Thank you so much, Dr. Moyo, for unpacking for us the testing strategy. We have just 3 minutes left, and I would request the presenters, each one is going to be given 1 minute to answer a question that has been posted in our chat. And the first question will go to Sikhulile, the second one will go to Ndlovu, the next one will go to Dr. Yenew as we part. So the first question we have that we received from the chat to Dr. Moyo is from Samuel Okrol, who is saying, what's the effect of the viral transport medium on the antigen test? And also Elizabeth, in the same vein, says, when do you repeat the antigen tests? Why not advocate for gene expert or PCR? So those two questions in 1 minute, Sikhulile, then we go to Ndlovu. Thank you.
Thank you for the question. The effect of the viral transport media. When the antigen test came out, there was clear evidence that some of the viral transport media, they actually inhibit the antigen test. So it's important to follow the guideline of the manufacturer, as if you use a different viral transport media, the results, it may not be successful. So other antigen tests may come out that can use any viral transport media. So there's inhibition of the reaction in some of them. So you really need to follow exactly what the manufacturer has recommended. The other question was, why repeat antigen test? Why not go to gene expert or PCR? As you could see, we said preferably if you have nucleic acid testing. So in the guideline is giving countries an allowance to see what will work in their context. If you have access to gene expert, then you can employ it there as a form of nucleic acid testing, or you can do PCR as a form of nucleic acid testing. But the guidance is allowing that flexibility for in-country to come up with your own implementation strategy. Thank you.
Thank you so much for that clarification. The next is to Ndlovu. It's from Ayana. It says, please comment on the value and feasibility verification exercises prior to implementation of COVID antigen RDT at full scale. Ndlovu.
Okay, thank you so much for that very important question. The issues around verification and validation. So this is very critical, especially when we are looking at the introduction and access to the COVID antigen test. So right now, it's encouraged that when countries conduct these studies, they have to do small studies, which are referred to as verification and not the full validation. Given that these have already passed the WHO, EUL process, so countries are being encouraged really to limit to small studies, so that the access to these important tools is promoted, and people can get to testing. So my quick answer to that is countries can do some small studies just to make sure that they are working properly, but not extensive studies. Over.
Thank you. And lastly, to Dr. Yenew, there are a couple of questions that have come through, but time will not allow us, and we would like to encourage the attendees of this webinar that all these will be answered. We shall post them. But one particular one to Dr. Yenew is from Elaine Bok, who says, thank you for the presentation. But the question is, are there plans to expand next generation sequencing capacity in the African Union region to detect the new variant of COVID-19? Can we be sure that the current tests can detect the novel variants circulating in the region? And then there's another question from Henry talking about safety. People have been accustomed to using safety level 4 when they're handling COVID-19 samples. What about for the case of the antigen test? Back to you, Dr. Yenew. Thank you.
Okay, thank you. Thanks, Silver. Thank you for those questions. The pathogen genomics, we are really working very, very hard to expand the testing network. So we have started in Southern Africa region, where we gave funding to centers of excellence in Southern Africa region. Now we are coordinating specimen transportation. to the Center of Excellence for quick sequencing and sharing of data. And moving forward, we are also coming up with the recommendations that there should be at least 50 sequences per country. To do that, we are preparing grant for those centers of excellence to receive samples from neighboring countries. So we are also in discussion with Gates Foundation to get additional funding. So there will be a lot of work on that. We have already a team that's coordinating this. We also work with WHO Afro to coordinate specimen transportation. So on the safety issue, in terms of the current diagnostics, if they can detect the new variants, so there is a small team led by FIND that's developing a short communique to member states describing what will be the impact of the new variant on the different diagnostic tests. So far, the anecdotal data shows that performance still is fine, but we will be sending out details in a form of communique to member states. The safety, this is my understanding that this is a very simple rapid test. So, of course, sample collection should be with all infection prevention measures. But in terms of processing the testing, so it will be a simple rapid test. So it doesn't require biosafety level 3 or 4. Even, PCR was not requiring that level. So this will be like, a simple rapid test as we do for HIV testing. Thank you.
Thank you, Dr. Yenew. And to add on the last point where I have added is that the PCR assays, we transport the sample or the virus in the viral transport medium. So the virus is actually viable. The rapid diagnostic tests that we have, actually when you put the sample in the buffer, the extraction buffer, it actually lyses the virus. So that's one of the basic reasons why the safety when you are dealing with the Rdts, the risk is not as high as when you are dealing with a sample that you have collected for PCR. So that was just to add on what Dr. Yenew has said. So at this point, we are 7 minutes on top of the hour. We respect everyone's time, everybody committed time to come here. For the questions that we have not been able to respond during this webinar, we are going to collect all of them and shall be able to respond to them. You visit our website. And at this point, we would like to appreciate all the partners that have made this session possible, Africa CDC, ASLM, and all the other partners. We would like to appreciate all the participants who have come up in big numbers to attend this session. We value you, we value your time, and thank you for the comments and the feedback. To my co-hosts, thank you so much for supporting, providing technical backgrounds and backup to make sure that the session goes on very well. At this point, we would like to encourage you to wait for be able to download your certificate through the code that some of you have been able to in the previous sessions. The method has not changed. At this point, we would like to stop here. Wish everyone a nice day and please stay safe. Keep all the SOPs for safety. We meet again in the next session when it is communicated. Thank you so much and bye-bye for now.